Good afternoon, everyone. Welcome to today's research conference. It's a real pleasure today to introduce Gerald Bloomfield, who's going to talk about global CBD. Now, when all of us think about global health, often we think about infectious diseases, but a growing recognition of non-communicable diseases is been supported by lots and lots of data suggesting that non-communicable causes of global morbidity and mortality really center around cardiovascular disease, and we have one of the world's experts and rising stars in studying this, particularly in some areas that we'll probably hear about today. So Jerry came to Duke by way of Princeton as an undergrad, and then Johns Hopkins, where he did his medical school training with an MPH, and then came here for, he stayed there for internship and residency, and as well as chief residency, and then came to Duke for cardiology, where he also completed advanced training in cardiovascular imaging, and then fellowships that were supported by the Fogarty International Clinical Research Program, as well as the Duke University Hubert Jurgen Center for Global Health. His research interests center around the epidemiology of heart failure and cardiovascular risk factors in the developing world, specifically in sub-Saharan Africa, and currently supported by a Career Development Award by the Fogarty International Center, as well as the NHLBI. Please join me in welcoming Jerry.
Thank you, Abdul, for that very kind introduction and for the invitation to be part of the DCRI Research Conference Series. It is my pleasure to speak to colleagues and friends about a topic that is near and dear to my heart, which is improving cardiovascular health, a global perspective. The objectives for this session are to discuss the burden of non-communicable diseases and cardiovascular diseases globally, to describe the clinical education and research programs of the Duke Moy Center of Excellence in Kenya, which is focused on cardiovascular and pulmonary disease, and to highlight Duke efforts in global cardiovascular health in developing countries. I have no conflicts of interest, but I am happy to disclose that the work that I'll be talking about today is supported by a K Award from the Fogarty International Center, which has allowed me to spend as much time as I do in Kenya. Before we dig into global cardiovascular health, I thought it was important to make sure we were all on the same page in terms of what we're talking about. What is global health? A lot of ideas come to different people's minds. Is it about international health? Is this about infectious diseases? Is this charity work, something you do in your spare time? Issues around social justice, etc. Different ideas may come to your mind. Is it the fashion of the day? Is it just the novel and neat thing to do? Well, I think we're fortunate here at Duke to be surrounded by people who think about these things, one of them being Michael Merson, who's the director of the Duke Global Health Institute. And he and colleagues a few years ago put forth a definition of global health that I think is instructive, and I'll read it for you. Global health is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions, involves many disciplines within and beyond the health sciences, and promotes an interdisciplinary collaboration, and is a synthesis of population-based prevention with individual-level clinical care. A fairly comprehensive definition. For the purposes of cardiovascular global health and for some of the reasons that I've been involved in this issue, there are a few points that I'd like to highlight and then speak about as we go through the rest of the presentation. So number one is equity in health. A patient who has a myocardial infarction in New Delhi should expect to receive the same high-quality care that you might expect in Durham. Transnational health issues, determinants, and solutions. Cardiovascular diseases like the ones we see and treat here in Durham are not isolated to high-income countries, and we'll talk about that in a second. Population-based prevention with individual-level clinical care, which has been a hallmark of our efforts in Eldoret, Kenya, which again we will discuss. My own introduction to cardiovascular global health started a few years ago, back in 2003, when I was a junior resident in internal medicine residency. You can do some math if you'd like or not. Where as a medical resident, I was invited by a colleague of mine who is a medical missionary to come and work in his center in the middle of Kenya. Here are some pictures from the environment around the Kijabi Medical Center in central province of Kenya. no tall buildings, no paved roads, or not a lot of paved roads, not a lot of businesses other than shops on the side of the street. A home in the bottom picture you can see is made of mud. They're often made of dung or wood. So not a place that you would expect to see a lot of myocardial infarction or stroke or the types of things that we see here in Durham. This is the part of the world where you'd expect to see more cardiovascular diseases related to infectious diseases. And I saw a lot of that back in '03. On the left side of the screen is a picture, a still frame echo image of rheumatic heart disease. This is a rheumatic mitral and aortic valve in a patient with rheumatic heart disease. But I also saw a lot of conditions such as the one on the right, which is a patient with a huge abdominal aortic aneurysm secondary to uncontrolled high blood pressure. So these types of images struck me, and these types of patients struck me, and I came back and wanted to investigate a little bit more in terms of, was this happening in other developing countries around the world? Flash forward now many years, we have the luxury of studies like the Global Burden of Disease study, which tell us a little bit about the causes of death around the world. So this slide shows the causes of death in developed countries in 1990 and in 2010. It's hard to tell green from blue here, my apologies, but the top few bars are green bars, which represent non-communicable diseases. The pink bars represent communicable or perinatal diseases, and the green bars on the bottom represent injuries. We can see that in developed countries, high-income countries, between 1990 and 2010, the top causes of death were non-communicable diseases, and the top causes of death haven't changed that much in the last 20 years. The situation is rather different in developing countries. So using the same scheme, between 1990 and 2010, now the top causes of death in developing countries are actually non-communicable diseases and no longer infectious or communicable diseases. The top 3 causes of death in developing countries, low and middle income countries, are stroke, ischemic heart disease, and chronic obstructive pulmonary disease. I would be remiss if I also did not mention HIV/AIDS being the 6th most common cause of death in 2010, over a 400% increase in developing countries between 1990. HIV/AIDS is still a very relevant issue in developing countries, but the top causes of death are these chronic non-communicable diseases. Another problem, or another issue around non-communicable diseases in developing countries is that these diseases affect individuals earlier in life than they do in developed countries. These are more data from the Global Burden of Disease study. On the y-axis, you see numbers of deaths in millions. On the x-axis are different age categories. Developing country data are shown in the yellow diamonds, and developed country in the red squares. And what you see here is that starting at age 30, but definitely by age 40 to 50, that the sheer number of people dying from non-communicable diseases is twice, if not 3 times higher in developing countries compared to developed countries, affecting people in their prime of life, their most productive years worth of life in terms of economic growth for a country. Let's focus in on cardiovascular disease. These are data from the Global Burden of Disease study in 2004, deaths from ischemic heart disease. This graphic shows the mortality rate from ischemic heart disease in the darker red colors, indicates a higher mortality rate. If someone has ischemic heart disease, they're more likely to die from that ischemic heart disease in developing countries compared to high-income countries. And this gets into issues of access to high-quality medical care, access to medications, awareness of the condition, etc. It's projected that if we look forward now a few years, that the overall deaths from cardiovascular disease worldwide will nearly double between 1990 to 2020. But interestingly, the majority of this increase is going to be due to deaths from cardiovascular disease in non-Western or developing countries. This is a huge issue for this part of the world. The issue is it gets even a little more subtle in that it's not just an issue of swapping out one cause of death for another. It's not a zero-sum game where if the death rate from infectious diseases are coming down, then by necessity the death rate from chronic diseases will increase. It doesn't quite fit that pattern. On the y-axis here, this shows the mortality rate from infectious diseases in the dark bars and chronic diseases in the light gray bars. For purposes of illustration, I'm going to focus on East Asia. Let me use the mouse here. That might show it a little better. I'm going to focus on East Asia in the years 2002, 2015, and 2030, and compare that to the high-income countries here. So if you look at the mortality rate decrease in infectious diseases over that time period, that's the slope of the change, this yellow arrow. If you invert that arrow and look at the, take the positive of that slope, that would be the expected increase in mortality from chronic diseases in East Asia, in a developing country region, if it was just a matter of flip-flopping the mortality rate. But actually what we see is a much steeper slope in the increase of deaths from chronic diseases in this developing country region. Further, now let's compare that to high-income countries. The increase in deaths from chronic diseases from East Asia is just represented here by this dashed orange arrow. And we see that the actual rate of increase in high-income countries is a lot lower than you'd expect compared to a developing country region. So just underlining the point that, number one, the chronic disease death rates are increasing at a faster rate than the infectious disease mortality rate is decreasing. And the rate in developing countries is a lot higher than in high-income country regions. Now, I spend a lot of time in Kenya, about 6 months out of the year, which is why many of you are wondering, why is he back in Durham? I thought he was gone. I spend a lot of time in Kenya. So let's focus in on some statistics from Kenya. These data report on the disability-adjusted life years from a variety of causes from the Disease Control Priorities Project in 2004. 2004 was a big year for developing countries, a big year for Kenya. That was the year that the President's Emergency Plan for AIDS Relief, or PEPFAR, was announced. HIV/AIDS, on everyone's radar at that time. If we look at the disability-adjusted life years in Kenya at that time, HIV/AIDS a clear number one at 24%. But a very close number two is this non-communicable disease chunk of the pie at 20%. And if we focus in and look within this non-communicable disease slice of the pie, so to speak, and ask, well, what non-communicable diseases are causing the disability-adjusted life years or deaths in this example, we see that cardiovascular disease is the clear predominant cause of non-communicable disease death in Kenya, a developing country, in 2004 at the height of the HIV/AIDS era. Global health in non-communicable diseases is a challenge, definitely because of the disease burden, but also because the relative inattention and, as these authors put it, the misfinancing of global health. On the vertical axis here, these are the total number of disbursements. These are dollars given to global public health efforts around specific diseases. On the x-axis, we see the mortality in millions from various diseases. And what I'll draw your attention to are the disbursements compared to mortality for HIV/AIDS and non-communicable diseases. Now, no one would argue that the magnitude of the HIV/AIDS pandemic warranted, or would argue that it did not warrant a large and rapid response. There was clearly a need to do that. But I would note that the funding for non-communicable diseases in comparison to the mortality that we see from these diseases globally has just not caught up, and there is indeed a misfinancing around global health. So let me transition here, moving away from the burden of disease, and talk about one approach that we've taken to combating this epidemic in sub-Saharan Africa, specifically in Kenya. So I'll talk about our Global Cardiovascular Research Partnership. We have been fortunate to be able to piggyback this cardiovascular research partnership on the foundation laid by a very long-standing, rich, vibrant primary care program in Kenya. This partnership between Moi University in Western Kenya, or led by Moi University in Western Kenya and Indiana University in the US, is called the Ampath Partnership. Ampath stands for the Academic Model Providing Access to Healthcare. It's an over 20-year partnership between Indiana University, a consortium of North American universities, and Moi University. It's been focused around primary care in Kenya. The motto of the Ampath program is leading with care. So it's primarily a care delivery program, a health system strengthening program, but research and education follow quickly behind the care program. The way the consortium is set up is that each partner institution is a therapeutic area leader in a specific discipline. So starting around 2008, 2009, led by Ralph Corey at the Hubert Jurgen Center for Global Health, Cynthia Benet, who's here from the Hubert Jurgen Center for Global Health and the DCRI, Eric Velasquez, who many of us know at DCRI, and myself when I was a fellow, started to ask the question whether or not it made sense for Duke to join this consortium around cardiovascular disease care and research. Luckily, at the same time, the NIH was asking similar questions. In partnership with United Health Group, the National Heart, Lung, and Blood Institute put out a solicitation in 2008 to create cardiovascular and pulmonary disease centers of excellence in developing countries to train and generate the next generation of researchers in these areas. The way that the centers of excellence would be formed, the leadership of the centers would actually be housed in the developing country, but in close partnership with the developed country partner. Duke was fortunate enough to be partnered with the Kenya COE as the developed country partner. Duke also partnered with the China Center of Excellence. I won't talk any about the China COE for the rest of the talk, but that was led by Mike Merson from the DGHI and also Bimal Shah, who was here in cardiology. When we put together the COE, we had 5 main programmatic goals. Number 1 was to organize an administrative core for cardiovascular care and research, to develop and implement a clinical curriculum, to establish a clinical research training program, to enhance the existing data and laboratory needs that were surrounding HIV care, to enhance those for cardiovascular care, and to implement context-specific and resource-sensitive projects that were predominantly led by the fellows in our program. The Kenya COE, the Ampath COE, was distinctive from many of the other COEs because of goal number 2 here. So this was an NIH grant, was predominantly focused around research, research education, research training. But when we began our partnership with our colleagues in Western Kenya, we realized that there was the clinical underpinnings of any good research program was lacking around cardiovascular disease. What does that mean? So when we started working in 2009, we did a little research and found out that for patients who need adult cardiology care, they could only be found in the capital of Nairobi or on the coast in Mombasa, of about the 15 or 16 or so cardiologists that were in the country at the time. We work in a city called Eldoret in the western part of the country, which is shown here by the blue X. And for our catchment area of 25 million people, that includes people from Kenya and also surrounding countries, there were 0 adult cardiologists at the time. There was 1 pediatric cardiologist who was a very busy woman who had to cross-train a little bit, but this was the clinical situation when we showed up. So what did we do? So we thought, first of all, before we could engage in good clinical research, we needed to make sure that the clinical part of it existed. So we adopted a multidisciplinary training model for cardiovascular disease, both care and research. We did not focus only on physicians, realizing that for the whole pie to work well together, we needed many types of individuals to make this work. So we've trained physicians over the last few years, but also nurses, technicians in our EKG and our echo labs, community health workers who would extend our reach beyond the referral hospital where we would base to be able to screen, diagnose, and treat patients far away from where we were at the referral hospital, and also administrators who would actually make this whole thing work. From a physician standpoint, we started the first cardiology fellowship program in the country. It still is the only certified, or the only fellowship program in country that I'm aware of. We're based at the National Referral Hospital, which affords us access to not only patients with advanced cardiovascular disease, but also other consultative services. We developed an inpatient presence with a cardiology consult service, as well as our own ward and a footprint vis-a-vis a CCU, which I'll talk about in a second. We have an outpatient presence in a cardiology cardiology clinic that has grown tremendously over the last 5 or 6 years. When I started working in Kenya in 2009, our cardiology clinic was run by about 3 or 4 practitioners, general internists, and on a busy day, we would see about 30, 35 patients, and we would go home tired. I was just in Kenya a few weeks ago, and right now, between about 4 or 5 practitioners, we're seeing about 95 patients in a day, and this is a once-a-week clinic. Wrap your head around that. We're fairly busy. We've trained nurses, 15 CCU nurses that we've trained over the last few years to run our unit, EKG and echo techs, some of whom have come over to the US and gotten certified, and community health workers, as I mentioned. Now, for anyone who has not worked in the developing country or a low-income country setting, I thought a picture is worth 1,000 words. So this is a picture of what a very good district hospital looks like. This is their general medical ward. This is really good. I think they knew we were coming, so they sort of cleaned up and got everything ready as well. But very clean, adequate for what they need to do. But if you're looking for the other things you might see around a patient's bed, a place for patient belongings, gloves, IV poles, other things that you might envision in a hospital room, they're not here. This is a picture from the web from our actual hospital in Eldoret, Kenya, Moi Teaching and Referral Hospital. A picture of one of the teams rounding. Again, you'll notice if you're looking for a lot of the bells and whistles that you might expect around a patient bed, it's not there. The IV line here is hanging off from a shelf. But what probably is catching your attention, or you're wondering, is who are these 2 women in the bed? So they are not relatives. They didn't know each other prior to the hospital. One is not visiting the other as an inpatient, but these are 2 patients who are sharing the bed. And this is not uncommon at all. The hospital capacity where we work is somewhere around 100. The usual bed capacity is somewhere around 150% in terms of being filled, because patients are usually 2 to a bed. In fact, when I walk through the wards and I see that there's 1 patient on every bed, many of us who've worked in Eldoret, you know that there's something wrong. People aren't coming to the hospital because there's usually more than 1. But from a clinical cardiology standpoint, if you could imagine trying to take care of a patient with advanced heart failure who has difficulty lying flat, a patient with an arrhythmia who you'd want to monitor continuously, someone with a myocardial infarction who's having chest pain who you want to manage acutely. It could be challenging, although we did this for a few years when we first started out. So based on our collaboration and with generous donation from the Hawk family through the Hubert Jurgen Center for Global Health, in partnership with Moi University, we built the first cardiac care unit west of Nairobi in the country. This is a 10-bed unit. We opened it in 2013. This is a picture from when we first opened the unit. It was still being worked on in the back there, but there are monitors by most of the beds, oxygen, IV poles, etc. Here's a picture of one of our, a picture from one of our first patients in the unit. I'll bring attention to this gentleman next to the woman in the red shirt, who's Dr. John Lawrence, who's been really the anchor for our clinical education program for our fellowship training there. We see Eric Velasquez here, whom we all know and love, who was there during our opening. This is another picture, a little bit more recent, of activity happening in our unit. One of the ways that we've been able to achieve our clinical education program for our fellows is we've had cardiologists who've retired from practice in the U.S. who go to Kenya for a few months out of the year to be our clinical educators. This gentleman is Dr. John Burks, who was here for Duke Fellowship a while back, who's retired from practice in the U.S., but clearly is not yet retired. And there are a number of other individuals who've come and play that role. I said this is not only about physicians. Here's, many of you may know Corey Miller, who's from the Duke CCU, who's come over in a nurse educator role. But it also has not been unidirectional. We've really had a bidirectional exchange where we've had our trainees come to Durham. This individual is the first graduate of our cardiology fellowship program who spent some time here on the cardiology units. We've had nurses from our unit come over for rotations here with Cynthia Benet as well as Marianne Fuchs on the nursing side. This is another picture of our Kenyan colleagues here at Duke Hospital. I'll draw attention to not only our nurses, but this fine junior resident by the name of Titus Nyeno, who was a medical officer with us in Kenya for a few years and then applied for internal medicine residency and is now a junior resident here at Duke. So we've really been able to fertilize and cross-pollinate across the ocean. But if we were all work and no play, we'd really be a boring group of people, and I hope that we're not. So we've been able to do some things both inside of work, some activities around advocacy, which have been fun, but also just getting to know each other and getting to know a little bit about Durham and about Eldoret. We've had a number of milestones. I won't read through all of these within our Center of Excellence. Some of them I've mentioned already. I will highlight that now, instead of 0 cardiologists in this part of the country, we now have 1 who's certified by the Kenyan government based on the clinical training that we've delivered over the last few years, 1 that's eligible and soon to be certified. Our Cardiovascular Fellowship program is in the process of being adopted by the local university in the spirit of sustainability and transitioning to more local ownership of what we're doing. Our CCU that was built is actually a revenue-generating center for the hospital, which again talks about issues of sustainability and this being an attractive partnership. From a research standpoint, we've had a number of publications, a number of awards, and have trained a number of individuals through an online clinical research training program as well. But let me talk about some of the research projects which are equally as exciting as some of the clinical and education projects that we've had over the last few years. I've listed some of the research themes. I won't talk about all of these, but I put these up just to give you a sense of the types of research that we're doing, the topics that we've addressed, which have been in response to the local needs and the local epidemiology, and also what we project to be the needs moving on into the future. I will talk about 2 projects in particular. One is around cardiovascular disease, HIV, and mortality. And if those 3 ideas don't fit well immediately in your mind, I'll give you a little bit of rationale. So we know, mostly from studies based here in the US, that people who are infected with HIV have increased risk of cardiovascular disease compared to the general population, whether it's due to chronic exposure to the virus, chronic immune dysfunction, exposure to opportunistic infections, long-term exposure to antiretroviral therapy that's still being parsed out. But for one or all of the above reasons, we know that there are higher event rates of MI, for example, myocardial infarction, in the HIV infected. HIV, though, if you look worldwide, most of the actual burden is in sub-Saharan Africa. In fact, of all of the people infected with HIV worldwide, 70% reside in sub-Saharan Africa. In addition to the sheer numbers of people who reside there, HIV, the epidemiology is a little different in sub-Saharan Africa. So there are more women represented in sub-Saharan Africa compared to the relative underrepresentation of women in some other cohorts. The type of therapy that patients are exposed to are different from some of the cardiotoxic regimens that were earlier available in the 1990s here in the US. And there are fewer cardiovascular risk factors such as smoking. So we see this population as a little bit more pure, so to speak, from a cardiovascular risk factor exposure standpoint, and a population whose life expectancy is increasing, and that we can understand the relationship between HIV and cardiovascular disease a little bit better. So what we did is leveraging the infrastructure of the Ampath program and the extensive medical record system that's available in the program, we did a retrospective analysis of patients based on medical records. So we looked over a 5-year period at patients who were enrolled in the program. There are about 93,000 that met our initial criteria. We were specifically interested in those without AIDS because we think that people who have AIDS have a little different mortality projection than people without AIDS. We remained with about 50,000 individuals and retained most of those individuals except for excluding a handful. So about 49,000 individuals in this analysis. Our main outcome measure was the adjusted mortality hazard at 6 years according to various blood pressure categories, trying to parse out what the relationship was between blood pressure and ultimate mortality. I'll share with you a little bit of our data. On the left panel are data from women. On the right panel are data from men. Systolic blood pressure is on top, and diastolic blood pressure is on the bottom. These are survival curves. The lowest blood pressures are shown in the dotted orange lines, and the highest blood pressure, greater than 140, is in the dark blue line. And what these data show, specifically for men regarding systolic blood pressure, is that the risk of mortality was highest in those with the highest blood pressure compared to having a normal blood pressure. Number one. Number two, those people with the low blood pressure have clearly the highest mortality. Those people are probably sick for other reasons, but we were intrigued by the finding that higher blood pressure had a relationship to long-term mortality in an HIV-infected cohort. We were curious about whether or not someone's stage of HIV played into the relationship of having higher blood pressure. So of our men and women, we looked at those who had advanced disease, so clinically more sick but not yet AIDS, and not advanced disease. We did that separately for men and women, again, looking at the mortality rates according to blood pressure categories. Let me walk you through some of the findings we thought were interesting. So number one, having a low blood pressure is associated with higher mortality. And we weren't, again, terribly surprised by that because they may be sick for other reasons. This is true for men and women regardless of the degree of disease. What we were curious about was this relationship for men, suggesting that the mortality rate associated with having the highest systolic blood pressure was greater than having a normal blood pressure. And the confidence interval does cross 1 here, but we were intrigued by the overall relationship in men whose disease was not advanced compared to men whose disease was advanced. So what do we take away from all this? Clinically, the decision-making process in many HIV treatment programs in developing countries is all around HIV. And once someone's disease is well controlled, the thinking often doesn't go very far beyond that. So we think this is compelling for our own program and for programs like ours, that once someone's HIV disease is controlled, there are good reasons to consider other non-communicable diseases or cardiovascular risk factors in this population, because there is a relationship to long-term mortality. And now that might sound intuitive to this group, but because of access to medications, because of training of the clinical staff who are seeing HIV infected in these HIV treatment programs, it's not necessarily always intuitive. So this is very locally relevant to us. Let me switch gears and talk about one other project that's also interesting, that we've spent some time on over the last few years. So household air pollution is a big problem in many developing countries. Household air pollution related to the way that people cook and the way that people heat their homes. Again, a picture is worth 1,000 words. This is a picture of a kitchen in Western Kenya. The kitchen is usually a freestanding building separate from the rest of the house. And the way cooking happens is that women predominantly will be in these kitchens for many hours throughout the course of the day preparing the food, sometimes with children running around or strapped to their back. The stoves they're using are these traditional stoves in the bottom two pictures, where the stoves are made of clay and fuel is fed in through a hole in the side. This fuel will either be wood, it can be charcoal, it can be dung, or it can be crop residue. The problem with these fuels is that they're very dirty. So when they're burned, there's tons of smoke that's released into the air. And if you walk into one of these homes when cooking is happening, you won't stay in there very long. A lot of coughing, watering eyes. It's a difficult place to be for the novice, like myself. But these women are exposed to this for many hours over the course of the day. You can see on some of the walls the soot that accumulates from the smoke that they're exposed to. Ventilation is often poor, and if there's a window, it's often small. So there's a project that we were involved in to actually try out a locally improved stove to replace the traditional stove with a more fuel-efficient and a cleaner stove. We know that based on studies, again, from high-income countries, that better air quality is associated with better cardiovascular disease. But the relationship in low-income countries, and especially subclinical cardiovascular disease that we can pick up by echocardiography, was unclear to us. So we enrolled a small number of women who are a part of a larger study where environmental measurements in the parent study were performed using two environmental measures: particulate matter less than 2.5 microns and carbon monoxide, CO. Where all the women had a baseline echocardiogram and a clinical evaluation, as well as a health utilization assessment. They have a cook stove replaced, and then we follow them up at 1 and 6 months. For the purposes of today, I'm only going to show you the cross-sectional 1-month associations between levels of household air pollution and echocardiographic measures. We did this in women's homes for a number of reasons. The cardiovascular hemodynamics are measured either in their home or nearby. We used a portable laptop-type echocardiogram machine that was donated by Philips, and we did a very comprehensive echo assessment. I'll point out one individual here who's Dr. Anuba Agarwal, who's sitting here, who was a medical student at the time that this study was actually being carried out, who's now an intern in the Duke House staff, sitting here in the front row. But she was very instrumental in actually getting this study off the ground. So what did we actually do? So we replaced the traditional stoves with a locally improved stove that reduced emissions via this chimney that was put out through the wall so that smoke could be let outside, and actually has much better fuel efficiency. We did a lot of this in very rural parts of Western Kenya. This is a picture of me and our research assistant and our driver and our green Jeep going from house to house. This moving image here, where are the homes? I mean, to go from one home to another took many, many minutes. It was actually raining on this particular day. You can see the muddy road. I hope you're not getting sick by seeing the image bounce up and down, but imagine being in the car. Not a small undertaking to actually do a field-based study with as much quality as we did. Here's a picture of Winnie with an umbrella. We often did this in the rain. We often had to use a generator because electricity was not available in the homes, etc. So not a small undertaking. There's a lot of education that also went on, both for our ecotech as well as participants. What did we actually find? So again, 44 participants, middle-aged, not a lot of comorbid disease. I should say young women, not middle-aged, young women. All of them use wood for cooking, about 20 years of exposure to these cooking practices. So I'm showing you the tertiles of carbon monoxide and how they relate to various echocardiographic measures. Again, this is cross-sectional. So we found that for women in the highest tertile of carbon monoxide exposure, there was much higher pulmonary arterial diastolic pressure. That's usually something you don't want high. A lower left ventricular ejection fraction, which is something you want higher. 6 percentage points is a pretty good change, but no relationship between mean pulmonary arterial pressure and left ventricular global longitudinal strain. Graphically, what that looks like in terms of tertile of pollutant exposure, we saw a significant relationship between higher carbon monoxide exposure and lower left ventricular ejection fraction. We did not find this relationship with particulate matter 2.5. And as we look towards our 1-month and our 6-month analyses, the data has been collected. We're just in the process of analyses. Would be very excited to figure out if replacing these cook stoves actually improve subclinical cardiac function. As I come to the end here, one of the other points I wanted to communicate is, although I again spend a lot of time working in Kenya and thinking about our program in Kenya, that when you think about cardiovascular global health research at Duke, it's not just about Kenya. Here is an incomplete list of individuals who I know are engaged in cardiovascular risk factor and cardiovascular disease research around the world. I'm sure there are others that I haven't left off on purpose, but maybe I'm just not aware. But there are many other people here that I think as we look towards the future, there'll be more opportunities to leverage a lot of what Duke is doing around the world around global health. One person I will mention is this last individual, Melissa Burrows-Pena, who's a DCRI fellow and a cardiology fellow, who's working on household air pollution and cardiovascular disease in Peru. Melissa shared these data with me. She has done a similar study in Peru to the study that we've done in Kenya around household air pollution and echocardiographic measures. And just briefly, she's compared users versus non-users of biomass and found more echo abnormalities, certain echo abnormalities in the patients who use biomass fuel compared to not. So I think this is an area of research that's very fertile, and there are a lot of people working in it here at Duke. The last thing I'll mention is an issue about global health training at Duke. So there are a number of programs here available for medical students who are in their 3rd year of medical school who want to do research in global health. The Doris Duke International Clinical Research Fellowship, which supports medical student research abroad for 9 to 10 months out of the year. A global health clinical rotation for residents around Duke to spend 2 to 3 months at various places around the world. The Global Health Residency and Fellowship Pathway for the next level of trainee, residents or fellows who want to spend almost a year abroad engaging in clinical research. We're fortunate to be one of the consortia for the Fogarty Global Health Fellows Program for fellows who can spend up to a year engaged in clinical research in a developing country. And also, not mutually exclusive, but the Master's in Science of Global Health is also available to trainees in any of these programs or separate from these programs who want a different type of exposure to global health. And these are run out of the Hubert Jurgen Center and the Global Health Institute. I've shown a picture here of just some of the trainees that we've had. Some are currently in Kenya. Some are back from their training experiences. I will just highlight Dr. Roger Glass, who's the director of the Fogarty International Center at the NIH, who's very much interested in non-communicable diseases and global health, getting away from the paradigm that global health is only about infectious diseases, and a number of other individuals here. The future for global health, I think, is very promising, and I'm excited about the next 6 years of what we're doing. I think increasingly our clinical program will be more and more run by our Kenyan colleagues. We'll expand the reach of our Kenyan cardiovascular research platform, not just to remain focused on Kenya, but also other parts of East Africa and multi-site, including Durham. We think our HIV and cardiovascular disease research platform will help us to achieve that. We'll grow the research programs of the Center of Excellence to be involved in global trials, training, and more fellow and faculty exchange. Duke has a number of global partnerships around cardiovascular disease. I've spent most of the time here talking about Kenya, but I think there's really some opportunities to partner with other research happening in Peru, India, China, and others from around the university. This is a team sport. Like anything in good clinical research, it's a team sport. There's so many people to acknowledge. I had to reformat how the slide was presented to account for everyone here. But this really, the last few years of our Center of Excellence programs has been due to many of the people on the slide here from Duke, from Moy, Indiana, Mount Sinai, and Purdue. I'm particularly excited about the next generation of cardiology fellows who are coming through the program, who have decided that global health is something that they want to do with their career. We have two currently, Melissa Burrows-Pena that I mentioned, and Neha Pagadipati, who will help to lead the charge as we move forward. With that, I thank you for your time and attention. I'm happy to take any questions.
Thanks, Jerry. That was wonderful. I also failed to mention that Jerry wears another hat that I didn't mention at the beginning. He's the director of the Global Health Cardiovascular Program at the DGHI. So that was a wonderful overview. Any questions from the audience before I ask a few? I guess when I phrase it like that, it's sort of sorry. So please do feel free to ask Jerry questions. But that was, I think, a really nice characterization of actually the difficulty of field work. And you highlighted that a lot of the population around Eldoret is rural. As you know better than I, there's also a huge demographic transition where across the low and middle income countries, people are moving from rural areas to urban areas. Any thoughts or experience in Kenya related to sort of the demographic transition and cardiovascular burden there in Kenya, and then broadly?
Yeah, so it's a great question. I think Kenya as a whole has definitely seen this urbanization and some of the ill health effects related to it. It's the difference between rural and urban is pretty dramatic. Urban Nairobi might as well be any other major city around the world. Rural Kenya is very rural, as I showed in some of those pictures. One of the news articles that I saw last year in the Kenyan press was about the epidemic of childhood obesity in Nairobi. We read that in our newspapers here. We think about childhood and nutrition in rural Kenya, and it's all about malnutrition. We're trying to get kids up to a certain weight. So I think there's a real dichotomy that we could really learn from as Kenya does urbanize more.
As you work with colleagues there, what are some of the highest priorities for the folks in the cardiovascular field there at Moy to better understand, and the resources that they feel like they would like to see to improve care of the population that they serve? Yeah,
that's a great question. So two main priorities come to mind. So number one is clinical expertise. As I mentioned, in 2009, 0 adult cardiologists in this part of the country. We've trained 3. 2 are finished. 1 is still in the process of training. But 3 per 25 million, the numbers still don't quite add up yet. So I think more clinical expertise is definitely a priority, and it's something that we engage in, sort of irrespective of where our funding sources are coming from. The second, from a research standpoint, is interesting. I shared some of the global burden of disease data, which is these worldwide statistics. A lot of those statistics are you have to extrapolate or estimate what the death rates are or the causes of death are in countries where the data are sparse. And so local epidemiology, people are very interested in figuring out, what the causes of death are in Eldoret, Kenya, or in, in rural Kenya, or, how prevalent is myocardial infarction. We just don't know. So we definitely are sensitive to the global projections, but the colleagues I work with really are interested in more epidemiology and even sort of cohort-based studies to figure out what the disease issues are for us there.
Sounds like some great opportunities for trainees if they're interested, so that's great.
I have an economic question. Twofold. One, is there any national funding resources provided for this very remote kind of care, as one? And then two, how do you, as a 21st century doctor, who's got all the bells and whistles here, go back? It's like, as a finance weenie, taking away my computer or my Excel program, right? I mean, how do you go into these populations without all of those things that you've used for your diagnostic tools? I mean, I know you have some stuff from Philips and a few other, and certainly the Hawk contribution was significant for the beds and stuff, but I mean, you really are kind of going back to basics.
Yeah. So, great questions. From the economic standpoint, so there definitely are government-level resources to cater for the health needs of the rural population. Kenya is in a transition where the health services are sort of being decentralized, so they're meeting the needs of the population. One thing that we've struggled with over the last few years is that up until recently, the availability of drugs for something like hypertension or diabetes was restricted to hospitals. So you couldn't go to a clinic or a dispensary or sort of a lower tier health center and refill your prescription for your blood pressure pill or your diabetes medication, because these non-communicable diseases were seen as diseases that required specialization in a hospital somewhere. So we've been really fortunate to work with colleagues in Kenya, Kenyan colleagues who've been able to make that transition happen. So we're seeing more access in rural settings. From a clinical practice standpoint, I think you said it best. I mean, you just have to go back to basics. And it's not necessarily a hard transition when you don't have all the lab tests you usually order and all the scans you usually order and all the people that you can usually lean on. You have to go back to basics, and it's fun. I have actually learned a lot from my Kenyan colleagues in that respect. Where I am the student when it comes to managing sick patients and not having all of the bells and whistles we might see here in our clinical setup, where I learn a lot from them.
I would just like to put in a plug that even though our cardiovascular program is obviously the most robust, and we're interested in getting more cardiology fellows and/or faculty who like to engage either in a clinical rotation for electives for 2 to 3 months or the longer program. Duke also has a presence in pulmonary. Peter Kusin is here. We're very interested in getting pulmonary involved, and also Carmen Graffignino on the neurology side has made a commitment and is very engaged there too. So we're looking for more collaborators all the time that are willing to spend some time to participate in either research or clinical activities.
One quick question. Is there any potential for collaborations with other organizations that are even in this area, like IntraHealth International or Family Health International or Nourish International? I mean, is there common ground for you to do even more?
Definitely, the doors are open. We are housed in this consortium, the Ampath consortium, made up of about 8 or 9 North American universities and Moy University. So I've spent most of the time talking about what Duke is doing, but a lot of what we do is in partnership with other universities. But other NGOs that are operating in the area, we are open to collaboration. So I'd be happy to talk with you more about anyone to follow up with.
Great. Well, thank you for a wonderful presentation and a window into some wonderful work you're doing globally. Thanks.
Thank you. Well, yeah.